Hi, welcome to the Terminology Leading Practices stream of the SNOMED Expo 2021. I'm Krista Lilly. I'm a MAP terminologist with SNOMED International, and I'm moderating today's session. Please use the live Q&A in your AirTouch device to type your questions to the presenter. All questions will be answered at the conclusion of the presentation. I'm now pleased to introduce Denis Casaubon from the AMA, who will be presenting Synergistic Benefits. The CPT code set with SNOMED CT address shared global challenges in a variety of health systems. So Denis, please proceed.
Thanks, Krista. Hello, SNOMED CT Expo. Thank you for listening to this presentation on finding synergies between SNOMED CT and the current procedural terminology, or CPT. My name is Denis Casaubon, and I'm a product manager at the AMA, working on finding new ways to drive value in healthcare through our code set. The growing complexity in healthcare calls for more standardized data. SNOMED CT and CPT are leading terminologies to meet this challenge, and today we'll look at how you could use these interoperable terminologies together to provide value in many types of health delivery models. Each year, new challenges create spending gaps that drive health systems to look for creative solutions. COVID was particularly large, but there are countless others to deal with. Global healthcare costs were growing more than 8% per year before the pandemic, so there's even more pressure on health systems now to get more value from limited resources while also improving patient outcomes. One way to help health data become more actionable is by using SNOMED CT and CPT terminologies together. Each has particular strengths in the continuum of care. SNOMED CT captures the diagnosis, procedural components, context of the visit, and outcomes. CPT codes provide a uniform language for health services and capture the resources required for that treatment, which is linked directly to payment in certain scenarios. By using them together, you can make evidence-based decisions, reduce waste, and make better predictions of costs in providing patient care. This audience is quite familiar with SNOMED CT, so I'd like to provide some background on key concepts of the CPT code set and its supporting content. Trusted holistic concepts. CPT codes are used across health systems because of the code set's features and foundation. CPT codes represent episodes of care that cover actions that naturally belong together, resulting in about 10,000 codes. Comprehensive guidance. Since CPT codes are used in different scenarios, the related content offers comprehensive guidance that makes codes easy to use in context and in different software systems. This takes many forms, from coding instructions to user-sourced questions and expert answers, and deep dive articles to explore appropriate coding in specific situations. Physician-led governance. Physicians drive the governance of the code set, so it consistently reflects the current state of care. When practitioners have a standard language that reflects how they currently practice medicine, care can be benchmarked and reimbursement is more accurate. Linked to quantitative data. The long history of CPT code use and the paired resource data provide a wealth of information that can inform some of health's biggest challenges. There's no shortage of resources to analyze how care has been coded in CPT in modern medicine. The CPT code set is more than simply a set of codes. The structure includes components that serve to promote their consistent, accurate interpretation and application. The base makeup of the code set is straightforward. Each code has guidelines and instructions that support uniform use, as well as multiple descriptor types for use in different settings. The long descriptor is the foundation and is used in most software systems, and there are also consumer-friendly descriptors to improve patient engagement in portals and documentation, and clinician descriptors that add extra clinical context. Care is often delivered in different contexts, so we also create a set of modifiers to denote care variations in coding situations. As I said earlier, the code set is governed by a physician editorial panel that represents the spectrum of healthcare interests. Eligibility for new and revised codes depends on existing evidence for the procedure's validity, as well as documentation that the procedure is practiced broadly. The panel reviews and deliberates code applications and then votes on adopting changes. In some ways, having a code legitimizes the procedure, and different actors in healthcare seek out proof points like this when choosing how to account for new procedures. Individual members do not advocate for their specialty in this process, but the panel's diversity ensures an equitable approach. There are also specialized work streams to address developing areas of care, providing important perspective to the panel when evaluating these proposed changes. The group meets 3 times each year to evaluate these proposed changes to the code set and is supported by a large cast of volunteers and participants. After codes are created, there's another effort to assign the required resources to them where appropriate. This is a powerful aspect of CPT content, and here's how it works. Each code reflects a procedure or service that is not duplicated in another code. Practitioners are surveyed on the time, effort, training, and equipment needed to perform the procedure. These resources needed are expressed as units called relative value units. And the 2 relevant components of those here are physician work units and practice expense units. For example, an equipment-heavy MRI might require 3.04 practice expense units, but only 0.76 physician work units for the interpretation. There's more detail, but the main idea is that there's a fair, consistent way to describe the amount of resources that go into care. These units can assist with measuring utilization, defining physician compensation, acting as a basis for reimbursement, and a host of other analytics on a health system's operations. Every part of healthcare faces challenges where CPT content provides value. Some examples are displayed here from different perspectives in the system, whether policy setting government, care delivery groups, or enablers like integrators and researchers. It's clear that many entities need standardized coding for reimbursement and much more. Care settings need ways to benchmark and describe quality metrics, as well as robust data to support utilization decisions and physician compensation. System-wide cost reduction efforts depend on interoperability and benchmarking across regions. These challenges are similar across the world, and while CPT codes are used most heavily in the United States, their benefits are applicable much more broadly. CPT codes are currently used in over 40 countries, and the CPT code set is the national government standard in 5. The AMA licenses entities for use in the US, and we work with distribution vendors to assist with implementations internationally. And this global use means that CPT content is used in different types of systems for different use cases, and we'll go through some examples of how CPT content can support variations globally. As we look at these examples, they aren't meant to be exhaustive, and we acknowledge that these types can and do overlap in many countries. I'd also like you to think about where SNOMED CT shines in these examples and where you see the value and use of CPT codes, and the 2 together. Your input really helps us to address the difficult challenges that we face in healthcare, so we welcome any thoughts that you have. In single-payer systems, where it's important to measure the resources used to achieve quality outcomes, it's often difficult to roll up specific actions into groups that can be quantified and analyzed. The structure and hierarchy of CPT codes can help with this classification, and the link to RVUs can help with the more detailed resource analysis to bend cost curves. Better allocation can mean better access to care, which improves the health of populations. In fee-for-service systems, the focus is on reimbursement for care delivered. That sounds clear, but allocating care efficiently and keeping costs under control can be quite challenging. The structure of the CPT code set helps users to code efficiently, prevent duplication of documentation and billing, and benchmark across regions, all which support these efforts to reimburse care accurately. The support of RVUs adds another layer of information, so individual procedures can have a direct reimbursement, and the benchmarking of RVUs is used to drive hospital-based compensation in some cases. Many systems employ a hybrid approach where public and private administration need to work together. Reconciling differences in reimbursement while keeping care standardized is the key. And the CPT code set has a history of working in tandem with other terminologies, so there are flexible options to address these challenges holistically. Our last example is in value-based systems, where risk sharing requires transparency and agreed value in groups of care. The physician-based RVUs provide a resource expectation that could be easier to use when defining DRGs and HRGs, since getting buy-in from all parties is a critical step in implementing these arrangements. The long-standing use of CPT codes also provides a rich base for benchmarking, so the whole system can adopt best practices and share data more readily. It goes without saying that SNOMED CT has benefits in these systems as well. And here we can see how using the two terminologies together leads to even better results. Users can document care in fine detail with SNOMED CT, perfect for research applications and capturing details about diagnosis, procedures, and context, where users want to refine by any number of population characteristics. Translating to CPT where appropriate, users can also evaluate the resources and costs consumed in ways that don't duplicate the documentation of care. Each terminology has processes in place to ensure reliable and current descriptions of care, and the features of each are well suited to meet the needs of any health system type. Revisiting our care pathway, we see where these two terminologies shine and why using them together can provide much more visibility into the full continuum. SNOMED CT allows for robust patient intake and initial care documentation, and translated into CPT codes, it could unlock reimbursement and resource analysis. SNOMED CT is there on the back end to document outcomes, and those are available so each terminology can be used for appropriate quality and reporting measures and segmented analytics across the care areas. Here are some specific areas where this combined use shows high value. Adding a layer of resource definition on granular care capture lets a system optimize in each phase of care. Rolling up this care to multiple levels goes a long way toward addressing population health challenges. And accurately capturing value delivered on the way to defining payment takes many inputs into account, and the nuances of these two terminologies can help to improve the accuracy there. These benefits grow when digging deeper, as seen here on a more conceptual level. So we've seen how more detail in the care path can lead to much more transparency for local and system-wide usage. Tracking care at different levels allows for measurement of resources down to the individual procedure, across population for certain conditions, or at system-wide levels. Knowing how resources have been used with a long history of data enables better predictions. Predictions with clear action items can impact health at a population level. Then data-driven population health efforts can inform health policy. And finally, better utilization and informed policy can lead to greater access for patients who need specific care. The demands of healthcare change, so it's important that the language of healthcare changes as well. Speaking for the CPT code set, we evolve in many ways, from providing multiple descriptor types to opening channels for temporary codes that codify care that's too new to meet requirements for a permanent code. Areas like telemedicine, augmented intelligence, remote monitoring, and wellness coaching benefit from the visibility of this temporary code format. CPT curation stays close to its user base by capturing coding questions and producing different types of support content. We're also evolving the maps between SNOMED CT and CPT codes to make all of these synergies easier to implement and capture. Tune into our session later in the program to hear more about this mapping effort, and we'll cover the items on the right here. Things like standardizing the format, adding more process into the mapping creation cycle, taking a phased approach to improve and validate codes of the most interest, and looking to speak more with users of the terminologies and the maps. to understand where to go next. These maps and the collaboration between the AMA and SNOMED International create opportunities to bring more transparency and better service to patients. We'd love to hear your thoughts, so please come visit us in the booth and drop into our site shown on the screen here. Let us know what questions you have, as well as areas you're interested to explore through these complementary terminologies. Thank you.
Thank you, Dennis, for your presentation. And now can I ask that attendees give us a moment while we switch over from our pre-recorded content so that we can discuss the questions you've been submitting. And also please note that this session will be available on the event platform in the next 3 months. Okay, hi, welcome back. So let me remind you that you can enter questions using the AirTouch device that was on the bottom right hand of my screen. And so let's get right to it. We have some questions about RVUs. If I start using, I include the RVUs and guidelines that you mentioned. And do all CPT codes have RVU values?
Sure. So the CPT standard data file is what users normally begin with. That includes section guidelines, but not specific coding guidance. There are other data sets that we produce that have the full guidance on how the codes work together, how to report them together separately, the hierarchy information, and the RVUs. So getting the foundation of CPT codes is that important first step. And then we also have documentation to support larger system implementations of CPT content more broadly. So for the codes that do have RVUs, almost all of them do. There are a few exceptions where they don't, where the RVU assignment really doesn't make sense, and that includes Category 3 codes. Those are temporary codes for emerging technologies. So in terms of understanding what goes into them and how they should be reimbursed on the back end, there's not a ton of information there at that point. And then also Category 2 codes are not meant to be procedures. They're for measuring certain actions, and so those don't really translate well. And then there are some pathology codes that are not valued by the committee that does the assignment. And in general, there are about 2/3 of the CPT codes that have RVU values.
And when you say that means the HCPCS?
No, sorry. This we do get into that system where it's level 1, level 2, all over the place. So in the US, we say that HCPCS level 1 is CPT codes, and HCPCS level 2 are more national code set items that don't fit in CPT very well. And then within CPT, we have 3 categories of codes. Category 1 codes are the primary long-standing codes that are used to code procedures and services. Category 2 codes are used for measurement of certain tasks. And then Category 3 is for emerging technologies. So when telemedicine first started to become prominent, that's where they first showed up. And then all kinds of things with augmented intelligence and things like that are in the Category 3 bucket today. And there are different levels of evaluation that we take to decide whether a code belongs in one category or another. And that's an open process during the panel meetings to understand the level of use, the level of documentation for these procedures, and how they should be tracked going forward.
Okay, so and along those lines, the CPT codes, I think of this as being US based. So when you have the RVUs, are they tied to location? So will they change when other countries utilize CPT and those RVUs?
Gotcha. It could. So the way that the US uses them is that we assess the inputs that that go into each encounter or procedure or service, and that is where the time, effort, training, and resources come into play. And so that's kind of an abstract unit that will carry across nations. And then we use a conversion factor in the US to turn those units into reimbursement in our national system. Our private system also uses RVUs in different ways. There are more nuanced uses. And so whether the use is for reimbursement or analytics or any uses, there are ways that translate from country to country.
Okay, and a question along those lines. Why is it better to have resource management linked to care paths? Can't we use our finance team, or do we need to blend clinical and operational teams?
Yeah, this is a struggle that every system tends to have. A lot have really good processes in place to use direct costs when they analyze these care paths. So what we're suggesting is that more data is something that can lead to better results, especially when the data that we are getting with the RVUs fills the gap between the resources and how they're used, where financial analysis typically just looks at whether supplies and people are used on a procedure or not. This is really how they're used and what goes into supplying those resources. And because the CPT codes have been used at kind of the intersection of clinical and operational teams for a long time, they offer a great way to dig deeper into the resource challenges that most systems face.
Okay, so if a device is being used in Europe, are you saying that both a CPT and RV code are required to be approved by the AMA?
Possibly, it's not. RVU assignments aren't really required for a code to be used. So if there's a device or procedure that is being used, it would go through a process to determine whether it fits in a Category 1 or a Category 3 CPT code. And then once it's assigned a CPT code, then it can be tracked and used in a lot of different ways on that end. Like we mentioned with the other one, you can do a procedure and get reimbursed for it without having RVUs. But if the scheme has RVUs attached to it, then that's just a different way to reimburse it. RVU assignment is a linked process, but it is separate. So there are cases where CPT codes have 0 RVUs attached, and we have some more information in the booth about how the RVU process works, how those are assigned, and which physicians participate in that process.
Okay, for a few more questions. Can we submit 2 new codes to the AMA panel, even if we're not in the US and we have a practice that we would like represented?
Sure. We've had a lot of submissions from other countries. We do have certain literature requirements that are outlined for the Category 1 and Category 3 applications. The full rundown is on the AMA website, and we can direct you to that. Examples of requirements are things like that the literature is published in English. If the publication where the literature was published. We just need to know whether it was US or non-US publication. And then also the studies that were done, whether they were on US population or outside the US.
Okay, and literature requirements have to be in English. Is CPT available in only English?
Right now, we don't have any other vetted languages other than English. We're considering adding some translations of some of the descriptors in the US. And so that's kind of a step toward AMA vetted translations. I'm sure that other areas that are using CPT do translate them for specific uses. But the core isn't vetted by us. If there is a particular language that somebody is interested in getting translated, we'd love to hear that because we're looking at that process right now.
Okay, and can you talk about the more practical things like how do you actually get the CPT codes? Are they free or is there a license? How do you access the maps? That kind of thing.
Mm-hmm. So we have licensing through, I'm sure they're everywhere on the internet, but usually when we think about using CPT codes, we have a regular, rigorous process to update them. And so using the most current maps gives you or codes and maps gives you the most accurate way to capture these details. We have licenses directly through the AMA, and then we have distribution partners in the US and internationally. So there are lots of ways that you can find access to the current code set. There are options for free and low cost access, but we tend to evaluate on use case. So there aren't a lot of those situations that come up that are free, certainly low cost. So we can talk more in the booth or the website to get to that. And then the maps are just an extension of that. So as you're looking at the CPT code set, there's also a data file that holds all the maps. And those can go through our distribution partners as well. But the director of business or international business development, Dean Parisi, is in our booth, and he is happy to take your questions.
Okay, and we've got maybe one more question. So what are the sides of the SNOMED CT map? I mean, how many maps are in that map? How many concepts? And how often are they released?
Sure. So we have about 115,000 maps altogether in both directions. The rough breakdown is that about 70% of the concepts or the maps are classified as fully classified or partially classified. So pretty accurate crossover. And that represents about 35,000 unique SNOMED CT concepts. We update them annually and release them each January, usually on January 31st or close to that.
Okay. And I guess we can hear more about that tomorrow in the mapping session on Friday. Thank you again, Denis, for your presentation. If anyone else has additional questions, I encourage you to connect by way of the meeting hub or at the AMA booth. And thanks for joining us, and enjoy the rest of the expo.